Thank you, Chair. Good afternoon, dear colleagues. I will speak today about hypertension and renal outcomes in type 2 diabetes mellitus clinical trials. Type 2 diabetes mellitus it has increased cardiovascular risk and commonly coexists with hypertension and renal diseases. So it will be ideal to have one drug that can treat all these comorbidities. I will present data about blood pressure and renal outcomes for the three newest categories of antidiabetic agents. And these are the SGLT2 inhibitors, GLP-1 receptor agonists, and DPP-4 inhibitors. I chose these only categories because they are the newest, and we have more data about their influence in blood pressure and renal outcomes. The first section could be about the effect on blood pressure, and I will mention about SGLT2 inhibitors and blood pressure. We have several data from clinical trials showing that this drug category decreases systolic blood pressure by about 4 mm of mercury, and the effect on the systolic blood pressure is about 2 mm of mercury decrease. The highest decrease was observed with 25 milligrams of empagliflozin in the RCT of EMPA-REG, where systolic blood pressure was reduced about 4.8 mm of mercury and diastolic about 2 mm of mercury. Less decrease was observed with a 10 milligram of empagliflozin, which was similar reduction shown with canagliflozin, and this was about 4 mm of mercury in systolic blood pressure and about 1.5 mm of mercury in diastolic blood pressure. These results were similar in patients with diabetes and in patients with chronic renal disease, as shown in the CREDES study where canagliflozin was used. Similar results, but with lower reduction, was observed for dapagliflozin, where reduction of systolic blood pressure was 2.7 mm of mercury, and for diastolic 0.7 mm of mercury. These results were replicated also in meta-analysis, and I mention only the largest meta-analysis available because there are many studies about this topic. Mazzini and colleagues showed in 22,000 patients that systolic blood pressure decreased 2.5 mm of mercury and diastolic blood pressure about 1.5 mm of mercury. This was a study meta-analysis specifically testing the effect of SGLT2 in blood pressure measurements. The other meta-analysis, they had results about the systolic and diastolic blood pressure, but their main outcomes were about efficacy and safety. The meta-analysis of Piperidou showed a reduction in systolic blood pressure of about 4.4 mm of mercury, and the reduction in diastolic blood pressure was about 1.8 mm of mercury. Similar results from Vasilakou and Liakos and colleagues. And the visual depiction of the effect of SGLT2 inhibitors compared with placebo or active control showed that the systolic blood pressure was decreased about 4.4 mm of mercury. Now we move on GLP-1 receptor agonists and blood pressure. Several clinical trials show that these antidiabetic agents decrease systolic blood pressure, but they don't have any effect on diastolic blood pressure. The highest decrease was observed with semaglutide, which decreased systolic blood pressure 2.6 mm of mercury and had no effect in diastolic blood pressure. Dulaglutide, exenatide, and liraglutide were between about 1.5 to 1.7 mm of mercury reduction in systolic blood pressure, and the lowest reduction was observed with lixisenatide. These results were replicated in the meta-analysis of Zhao in 2019 about liraglutide, where systolic blood pressure was reduced about 3 mm of mercury. Another meta-analysis about semaglutide showed that 1 milligram of semaglutide versus placebo decreased systolic blood pressure about 3 mm of mercury, while the 0.5 milligram of semaglutide decreased systolic blood pressure 1.3 mm of mercury. So it seems that it's also a dose-dependent effect. Highest decrease was observed with oral semaglutide in the meta-analysis of Ayerinos and colleagues, and the highest decrease was observed with 14 milligram of oral semaglutide versus placebo, and that was 3.6 mm of mercury, followed by oral semaglutide 7 milligrams versus active comparator, which was 3 mm of mercury. I have shown that when we treat patients with SGLT2 inhibitors or GLP-1 agonists, they decrease slightly systolic blood pressure. What will happen if we have combination of these two drugs? Would be the effect higher or similar to the one of these categories? This question was answered by meta-analysis of Matthew and showed that when we use combination of these two categories, compared with either one of them, we have more decrease in systolic blood pressure. The highest decrease was when we used combination versus GLP-1 receptor agonists, and the decrease was 4 mm of mercury, while when the combination was compared with SGLT2 inhibitors, the decrease was 2.6 mm of mercury. We move on DPP-4 inhibitors and blood pressure. All clinical trials showed that this category has no effect on the systolic blood pressure nor diastolic blood pressure. Similar results were reported for sitagliptin, alogliptin, and others that I have not shown. Now we go to renal outcomes, which is more interesting topic. And we start with SGLT2 inhibitors. We have many data showing that this drug category has a renoprotective effect. From all this data, the highest, we have a similar decrease in the incidence of the composite renal outcome, the progression of albuminuria, and the incidence of end-stage renal disease. Empagliflozin showed a hazard ratio 0.61 for the composite renal outcome, decreased about 40% the progression of albuminuria, and about 55% the incidence of end-stage renal disease. Similarly, canagliflozin decreased 40% the composite renal outcome, 40% the progression of albuminuria, and the incidence of end-stage renal disease, about 23%. These results were similar also in patients with chronic kidney disease, as shown in the study Credence, with similar hazard ratios, and also in patients with heart failure with or without diabetes, as shown in the study of dapagliflozin, the DAPA-HF, and also in patients with chronic kidney disease with or without diabetes, as shown in the study DAPA-CKD. These results were replicated in the meta-analysis of Piperidou and colleagues, where 17,000 patients were included and showed that the treatment with SGLT2 inhibitors versus placebo or active control decreased the urinary to albumin to creatinine ratio by 25%. Also, the deterioration of renal function was decreased with the use of SGLT2 inhibitors, as shown in a very large meta-analysis of Q, where 58,000 patients were included, and showed that the deterioration of renal function was decreased by about 40%. The hazard ratio was 0.63. Now I will present the data about GLP-1 receptor agonists and renal outcomes. were similar to the SGLT2, the GLP-1 receptor agonists have renoprotective effect. All the studies showed that they decrease the composite renal outcome, the progression of albuminuria, and the incidence of end-stage renal disease. The best results were reported for semaglutide, where the composite renal outcome was decreased about 40% with hazard ratio 0.64. The progression of albuminuria about 40% with hazard ratio 0.54, and the incidence of end-stage renal disease with hazard ratio 0.91. Similar results were for liraglutide, exenatide, dulaglutide, and lixisenatide. These results were replicated in the meta-analysis of Avierinos, where 60 RCTs were included and 60,000 patients, and when GLP-1 receptor agonists were compared to placebo, urinary albumin to creatinine ratio decreased by 2.55 mg per gram, and when it was compared with the active control, the decrease was 5.52 mg per gram. DPP-4s and renal outcome, they do not have renoprotective effect as shown in the studies about composite renal outcome and the incidence of end-stage renal disease. However, it was reported for linagliptin that the progression of albuminuria was significantly reduced when linagliptin was used. The hazard ratio was 0.86. The meta-analysis of O'Hara showed the same result, that the DPP-4s do not have any renoprotective effect for creatinine doubling, incidence of end-stage kidney disease, or death from renal causes. Now, when we compare SGLT2, these three categories with all the antidiabetic agents, what happens? What will be the effect on renal function? A very large meta-analysis published in BMJ, where 764 RCTs were included, and all antidiabetic agents were compared with SGLT2 inhibitors and GLP-1 receptors, showed that the incidence of renal insufficiency was decreased significantly only with using SGLT2 inhibitors compared to placebo, where the hazard ratio was 0.71. For GLP-1 receptor agonists compared to placebo, about 22%. And this effect was not observed for metformin, sulfonylureas, thiazolinodiones, DPP-4 inhibitors, basal insulin, bolus insulin. And another meta-analysis which examined each drug within each category showed that this effect of SGLT2 is probably driven by the effect of canagliflozin, dapagliflozin, and empagliflozin versus placebo, where the hazard ratio for end-stage renal disease was 0.7 for canagliflozin, 0.3 for dapagliflozin, and 0.46 for empagliflozin, whereas the effect for GLP-1 receptor, it was not evident for each agent individually. In conclusion, we can conclude that SGLT2 inhibitors and GLP-1 receptor agonists decrease systolic blood pressure. They both have a renoprotective effect. However, DPP-4 inhibitors have neutral effect on blood pressure and renal outcomes. Thank you very much.